start, Kishore?
Dr. Lincoln, once you are ready, just let us know, then we'll.
Good evening, everyone. Good evening, respected seniors and my dear colleagues and juniors. Welcome to our academic platform, Onco Ocean. Today's session will be dedicated to our topic, oligometastasis in CA breast, followed by a panel discussion. For today's session, I would like to introduce our speaker, Dr. Lincoln Pujari, sir. Sir is Associate Professor in Department of Radiation Oncology, SBCH, PMMCC, Varanasi. He has key interest in breast oncology, GI oncology, uro-oncology, stereotactic radiotherapy. Sir is the principal investigator to ongoing phase 3 trials and has more than 20 publications in national and international levels. Welcome, sir.
Thank you for your kind introduction. So let's start. So we'll be discussing about oligometastasis in carcinoma breast. So we'll be concentrating particularly on this oligometastatic setting in this primary site only. We should focus on that. So to start with, let's first see what is the oligometastasis actually. So as defined by Hellman and Wisselbaum, it's an intermediate state between a purely localized disease and an widely metastatic disease. So as we can see, the natural history of the disease is such that from the localized disease, it reaches to a kind of intermediate state of oligometastasis before proceeding to a florid metastatic disease. So as per this picture, it's like in the localized disease, it's the low risk and local ablative therapy would be best possible treatment, which subsequently proceeds to the florid metastatic stage. Then the systemic therapy remains the only option, and the results are also very poor. So here lies somewhere in between this localized disease and disseminated disease, a state of oligometastatic disease where probably there is still a chance of cure in these patients as well. So to define oligometastatic disease, actually there is no standard definition as yet. There has been some consensus definitions of this, but they pretty much differ amongst the various societies and also as per the trial inclusion criteria. So for the time being, we can safely take it as up to 3 to 5 metastatic lesions. But the most important part is all of them should be amenable for curative treatment. So the number of lesions, the number of organs involved, and the size of the lesion, all these local factors become very important in this setting. More so, due to the use of modern, highly sensitive investigation modalities such as PET-CT, we are currently diagnosing more of these oligometastatic breast cancer patients. And probably with this Wills-Roger phenomena, when it's kind of a stage migration from the lower stage to higher stage, previously with the conventional imaging modalities or metastatic workup, probably these patients would have been treated in a curative intent, but we have, with the more sensitive tools, we have identified a oligometastatic setting and we don't know what to do with these patients. If we treat them as palliative, then probably it's an injustice. And also, as we have already diagnosed a metastasis, probably treating them with the conventional curative intent is also a doubtful question. So these dilemmas do remain in this setting. So as per this recent EORTC proposed classification, even so, they have introduced many terminologies pertaining to this oligometastatic setting, starting from the synchronous oligometastatic to the metachronous oligorecurrence and metachronous oligoprogression to repeat oligorecurrence, repeat oligopersistence, repeat oligoprogression, followed by this induced diseases. But it's a bit complicated to understand this. There is a full paper on this as well, but let's simplify it for our students. So we need to know basically these definitions. which may also be asked during your exams. So first thing is obviously the oligometastasis, where few or solitary metastatic lesions that are usually confined to a single organ and all are amenable for treatment. The term oligorecurrence comes when there is a limited metastasis in the presence of a controlled primary. So coming to the oligometastatic setting, there is a synchronous oligometastasis and metachronous oligometastasis. Synchronous comes when you diagnose this oligometastasis at the time of diagnosis itself, or in some cases, in some trials, it has been taken as up to 6 months of completion of the primary treatment. In metachronous oligometastasis, obviously the time frame is a bit longer, that is more than 6 months. And after completion of treatment, there is right now a few metastasis after a considerable time period gap or disease-free survival for the patient. Oligoprogressive is the setting where there is progression of a limited number of metastatic deposit while the others are well in control in the systemic therapy. So the oligoprogressive setting is essentially a polymetastatic setting where with the systemic therapy, the disease is controlled except in a few limited number of metastatic sites. So with this working definitions, let's proceed further. So let's see at the burden of the OMBC disease. So as we see, around 20 to 30% of all curative intent patient of early stage breast cancer may finally recur or become metastatic. And in all the patients which we see in the OPD, around 6 to 10% of the patient may present to us with de novo metastatic breast cancer. That is, at the time of diagnosis itself, we can identify that metastasis. So how does this OMBC behave and how is it special? So in all metastatic cases, basically, these are the two types of dissemination that happens. One is daughter metastasis to metastasis dissemination, and other is the parental metastasis to metastasis dissemination. What does it mean basically? The first one, the metastasis to metastasis dissemination in the daughter type, that is the metastasis represent an additional source of seeding. Like the metastasis gives rise to a source for the other metastasis. But in the parental metastasis setting, it is the primary tumor that leads to the dissemination of the disease for the metastatic disease. So these are the two basic types which we take into consideration while considering this metastatic disease. So there are some prognostic factors which we need to take into consideration while deciding the treatment plan for these patients. In this systemic meta-analysis, which included 20 studies which had OS analysis in them, in the combined analysis, the 5 were OS was in the tune of around 30 to 80%. There is a wide range of that, but because of this retrospective, most of the studies were retrospective in nature and various sample size with a varied degree of patient population. So these results were kind of this wide with this wide range. The 5-year PFS was also in the tune of around 25 to 57%. But upon the multivariate analysis of factors, solitary metastasis, more than 2 years of DFI, no or limited involved axillary lymph node at the time of primary diagnosis, and hormone receptor positivity. These factors were associated with favorable outcomes. So basically, with this premise, in this condition, if we diagnose oligometastatic breast cancer, then probably we can offer her or him a curative intent treatment. That's the thing. So how do we treat these patients? We have found an oligometastatic breast cancer. So as we have already discussed, if this de novo oligometastatic setting, less than 3 metastatic lesion, disease-free interval of more than 2 years, with well-controlled primary and premenopausal or perimenopausal with hormone positivity, these patients are a good candidate for metastasis-directed therapy. Similarly, we do see some patients who have isolated sternal metastasis or in some cases contralateral axillary metastasis. These represent a difficult situation because this contralateral axillary metastasis, this is not very clearly defined or commented upon by the AJCC staging classifications. the usual dictum is that if you find an axillary metastasis contralaterally and you cannot find a primary of that ipsilateral breast, then you have to investigate further, either by mammography. In most cases, the MRI of the breast can help. But even if you don't find any on any imaging modality, then probably still, even if you consider that as metastatic disease technically, but you can treat them as locoregional disease, like dissection of that axillary lymph node of that side only, and you can get away with the curative intent treatment of these patients. So what are the treatment options available for these oligometastatic breast cancer patients? So as we know, for liver site, we can offer surgery, radiofrequency ablation or SABR. For lung, obviously surgery and SABR. For brain also, we can use radiotherapy and surgery as well. Apart from this, bone SBRT or bone stabilizing therapies, even in surgery or some in systemic therapy. Obviously, the systemic therapy is still the backbone of the treatment of these patients, and subsequently other modalities, whatever is available at our armamentarium and at our disposal. So there is a small difference between the treatment of synchronous oligometastasis and metachronous oligometastasis. Basically, all the three options are available for use. That is the surgery, ablative therapy of the metastasis itself, and systemic therapy, obviously. But in synchronous oligometastasis, there is a question whether to treat the primary or not. Obviously, if we are treating them in curative intent, leaving behind the primary doesn't make sense. But let's see at the data. So how do we proceed with the locoregional treatment for metastatic breast cancer? So these are the 4 major trials which have evaluated the role of locoregional treatment of the primary in de novo metastatic breast cancer. They are not essentially oligometastatic breast cancer. As we can see in the ECOG-ACRIN trial, only 16% patients were oligometastatic. In the Tata Memorial study by Dr. Badway, only 25% patients were oligometastatic. In the ABCSG study, the oligometastatic disease was not specified, so the data on this is not available. And the Turkish trial, only 29% of patients had single mets. So, and the treatment arm also is a bit variable, but the end point is that all the above 3 studies, the study first, second, and third, they didn't show any significant benefit of these kind of aggressive treatment. However, this Turkish trial, at its 10-year follow-up data, it has shown a overall survival benefit, significant overall survival benefit over the observation or standard of care arm, that is systemic therapy only, for these metastatic breast cancer patients. So the data is still doubtful and not robust, but still we can offer local therapy to these patients as we are planning to treat them with curative intent. Obviously, the patient selection has to be pretty clear and pretty good for this. So, as per the recent ECMO metastatic breast cancer living guidelines version 1.2, in which was published in April 2025, they are also advocating that surgery of the primary tumor may be considered for patient with bone-only metastasis, hormone-positive tumor, HER2-negative tumor, patient who are less than 55 years, and patients with oligometastatic disease, and those with good response to the initial systemic therapy. So we kind of follow this type of protocol at our center as well in these patients. Now, coming to the second part, which is common to both synchronous and metachronous oligometastasis disease, that is the metastasis directed treatment. So how do we go about it? So the options are basically 3. First is surgery. The second is stereotactic body radiotherapy, SABR or SBRT, whatever we call it. And the third, also the important part, is the intervention radiology. They also play an important part in this treatment. So let's come to the first, to the data about surgery for metastasis. that is surgery for metastatic site in oligometastatic breast cancer, pertaining to breast cancer specifically. So as we can see, there is one systemic review with around 1,700 patients, which evaluated the intervention surgery in these patients, and the median overall survival was around 36 months, and 37% patients were alive at around 5 years. All other studies are basically retrospective in nature, but they somehow show that the surgery for metastatic site in this subset of patient is a good option to offer. Now coming to the SABR or the SBRT in metastasis directed radiotherapy setting, most of the trials are actually single arm or observational or mostly phase 2 trials, except one. This one is the randomized phase 2 trial, that is Thaber trial by Palma et al. So in this also we can see that with radiotherapy or SABR, addition of SABR to the standard of care, the overall survival and even the disease-free survival or progression-free survival is increased. Like in Saber Comet, the 5-year overall survival is 42% with the use of SBRT as compared to the only 17% in the standard of care arm. Other trials also have shown the single arm prospective phase 2 trials or the single arm prospective trials have shown encouraging results as well. Now, let's discuss the Saber Comet trial in a bit detail, because this is one of the most important trial, which is kind of randomized phase 2 trial. The only phase 2 trial full paper available as of now for oligometastatic cancer. So first things to note is that this was kind of a basket trial, including this primary site was varied. Breast cancer was around 18 patients only out of 99 patients were included, and there were other patients as well. And the lesion location of metastasis was also pretty much varied, with the bone metastasis reaching up to around 30 to 35% of patients. And lung metastasis was also seen in around 50% of patients. So here what they did is that they randomized 99 patients into 1:2 elevation, for the palliative RT or systemic therapy, which was the standard of care, and the other in the other arm they added SBRT to the systemic therapy. The primary outcome was overall survival to be estimated, and they actually found this result. The median overall survival with the addition of SBRT reached up to 4 years, more than 4 years, as compared to the 28 months, only 2.5 months around in the standard of care arm. Similarly, the progression-free survival also was almost more than double with addition of SBRT to the standard of care or systemic therapy. So now there's another option to offer in these patients, especially in cases of liver metastasis. Right now, the RFA is also kind of used in some cases of lung metastasis as well, but mostly the data is available for the liver metastasis. So this is one meta-analysis which has evaluated and compared radiofrequency ablation with SBRT for liver malignancy. Here they included both the primary liver, that is HCC, and some liver metastasis. So this study, which included around more than 2,000 patients and 11 studies, only 3 were pertaining to the liver metastasis and included 267 patients. Here we can see that 2-year local control rate with SBRT reaches up to 83.6% as compared to 60% of RFA. So in this subset of patient, that is liver oligometastasis patient, probably SBRT confers a better progression-free survival, at least for these patients. Now, coming to the systemic therapy, basically the systemic therapy remains the backbone of the treatment of these oligometastatic setting. So right now it's the era of molecular biology, and we all know that the biology of the disease is the king. So when we diagnose the metastasis, in breast cancer patient, we need to see many of these targetable lesions or targetable molecular targets if we can find any, because they are going to help us in the future for first line, second line, third line, and further. So basically, first we have to assess ER, PR, and HER2/neu. The best thing would be to take a repeat biopsy, which is actually needed, because many a times around 20 to 30% of these patients in the metastatic site, there is change in the nature of the molecular profile of that particular breast cancer. So ER/PR or hormone positive changes to hormone negative, HER2 negative changes to hormone positive or HER positive. This is kind of, there are different theories behind it, but let's not discuss or go into detail of that. But let's see how it affects our treatment decision. So basically, we have to take a rebiopsy, reassess the hormone status and HER2 status. Obviously, if it's TNBC, then there are panel which we may consider, that is the PDL1 testing, and obviously the germline mutations if they are available, like BRCA1 and 2 and PALP2. If it's HER positive only, then we can discuss about this MSI high or tumor mutational burden, NTRK fusion, BRAF mutation, and RET fusions. Similarly, if it is HER2 positive or negative, also we can see HER2 PIK3C, that is, and AKT pathway or PTEN pathway, ESR1 alteration, and obviously this BRC and PAL2. We have multiple targeted therapies against these mutations and downstream pathways, as we are going to see. So till now, we have taken a rebiopsy, we have classified, and we have studied the molecular profiling of these patients. Right now, how to proceed? So for hormone positive and HER2 negative patients, the basic idea is to start with metastatic disease systemic therapy. Basic idea is to start with a aromatase inhibitor with CDK4/6 inhibitor. In premenopausal, we can add the ovarian function suppression as well, either medical or permanent, that is surgical or radiotherapeutic. If the patient is having bone metastasis, then fulvestrant is obviously preferred. Subsequently, if the patient fails, then as per the molecular profiling, we can offer various treatment, like if it is PIK3CA mutant, then we can use everolimus, ESR. Some of these agents are actually not available in India as of now, but some are available. So we can choose between these. If it is BRCA mutant, then we can obviously offer this PARP inhibitors like olaparib, talazoparib, and urucaparib, etc. And if all of these have been exhausted, then probably we can again move to the last line in chemotherapy and whatever agent which has not been used till now. Similarly, for HER2 positive agents, we have many newly available drugs, like first line would be the Taxane, trastuzumab, and pertuzumab, that is combined HER2 blockade. If it fails, then we have the options of trastuzumab deruxtecan and TDM1. This trastuzumab deruxtecan can be used in HER-low setting as well. Apart from this, there is an option of tucatinib, capecitabine, trastuzumab. Tucatinib has become available in India recently. And after that, if there is further progress in the disease, then there are other options as well. In triple negative, obviously we have tested for PDL1, and pembrolizumab also can be added and should be added in these patients, which offers a bit of benefit in both progression-free survival and in some cases overall survival as well. In PDL1 negative, we can proceed with the chemotherapy. Or if BRCA mutant, then olaparib or talazoparib. Subsequently, in second line, there is an option of these other drugs as well. And subsequently, whatever drug has not been used, you can use that in third line. So this is the basic outline of this systemic therapy in the metastatic breast cancer setting. So there is still a lot of buzz in the scientific community about this metastasis directed treatment, and there are a lot of ongoing studies in this subject. Uh, many of the studies are recruiting from the mixed histology, that is varied primary site. We have proceeded to, there are some ongoing phase 3 trials like the Saber Comet. There are 2 trials ongoing from the Saber Comet group. Some other trials are also phase 3 randomized trial are also ongoing. And pertaining to breast cancer only, there are a few trials like Oligoma, Stereocene, Clear, etc. Few of them are also phase 3. So we'll have to wait for few more years, like around 3 to 4 years down the line, to get the results from these trials, and probably then the picture will be clearer, and we can choose the treatment for the patients wisely, and we can individualize treatment for probably all of our patients. So this is the thing about oligometastatic breast cancer. So what we should look into, first thing is that local ablative therapy in oligometastatic breast cancer can be beneficial, whatever is the data as of now. Although we don't have any robust phase 3 data available with us, but still we see in our clinical practice and with a lot of prospective single arm or retrospective study, we know that local ablative therapy is a treatment option in this setting. But we must keep in mind that the patient selection is the key. We just cannot offer the treatment to each and every patient. We have to choose wisely among the available treatment options as well, with or with consideration of what is best for the patient, what are the available treatment at our disposal. All these have to be taken into consideration. And lastly, the cost factor also needs to be kept in the mind. And finally, we must keep in mind and we must remember that the disease biology is the king, and we just cannot ignore that. So that's from my side. Thank you for your patient listening. Any questions? If you have any questions, I'm happy to take that. Any questions?
Sir, I don't see any questions in the chat box.
Okay.
Now we proceed towards panel discussion. Sir, I request you to please kindly introduce our panelist for today.
Just a second. So I have my esteemed panelists with me. Dr. Gaurav Goswami is a consultant radiation oncologist in Apex Super Specialty Hospital. Gaurav, are you there?
Yeah, Lincoln, I'm there. I'm there in
Yes.
the panel.
Welcome, buddy.
Thank you. Thank you.
Yes, Dr. Prashant.
Yeah,
He is the associate professor in Department of Radiation Oncology at our hospital, that is Mahamana Cancer Hospital, Varanasi. Dr. Abhishek Singh is a medical oncologist at Medanta Hospital. He is the director of medical oncology at Medanta, Lucknow. Dr. Abhishek, are you there? So, Dr. Deepak, he is the surgical oncologist, senior consultant surgical oncologist at Apex Super Specialty Hospital and Mahamana Cancer Clinic. And we have Dr. Shreya Sukla, who is the radiologist, assistant professor, Department of Radiology in Mahamana Cancer Hospital. Dr. Shreya, are you there?
Yes, sir, I'm here.
Yes, welcome, Dr. Shreya. So let's proceed. So this is a 36-year-old lady with no comorbidities, with 3 living children. Last childbirth was around 4 years ago. All children were breastfed for more than 6 months. She is premenopausal with regular periods, and she has presented to the OPD with complaints of right breast lump for the last 1.5 months. Am I audible?
Yes.
Yes. So on examination, there is an ill-defined lump of 6 into 7 centimeter on the upper quadrant. No PDO, skin is also free. No palpable axillary lymph node. And on examination, the contralateral breast and axilla and other systemic examination is also normal. And from outside, she has got an FNA report which states atypical ductal hyperplasia. So my question to the surgical oncologist, Dr. Deepak, are you there?
Yes,
Am
I'm
I
there.
audible?
Hi, Lincoln. How are you?
Fine, dear. So welcome. So how do we proceed now? This patient has come to your OPD.
So first of all, this patient has a huge lump.
Yes, 6 into 7 centimeter.
Yeah. So since
Mm.
we already have a FNAC, so we'll do a USG guided core biopsy to confirm the diagnosis. That is a true cut biopsy, at least 6 to 8 cores, so that we can actually get to know what is the actual histology or the pathology. Then we can proceed regarding the further workup or any management.
Yes, surely, Dr. Deepak. The house probably agrees with Dr. Deepak. So we can also have a radiological investigation, Dr. Shreya. How can this mammography or sonomammography help us in this patient? 6 to 7 centimeter lump, premenopausal, 36 years, 3 living children, and no
Yes, sir. So,
palpable axillary lymph node.
yes, sir. So the mass indeed is big, 6 to 7 centimeters. So this would lead to mastectomy invariably if it is positive for cancer. But
Mm.
it can also give us information about presence or absence of satellite lesions, even if they are not going to change the management. But we will be able to know the disease burden better after performing a mammography and further correlating the mammography findings with an ultrasound. And
Yes,
there can be less
yes,
likely differentials, of non malignant etiologies can also be ruled out by performing an ultrasound.
yes, surely. And the second thing is probably we have to evaluate the opposite side breast as well in these patients.
Agreed. So that's why a bilateral mammo.
Yes, sure. Now, the question arises, how do we stage this patient, or what metastatic workup do we proceed with? Dr. Gaurav, would you like to come in?
Yeah, sure. So, firstly, the thing is that the kind of setup which you have. So, I'm going to break this question into two parts. The answer. The first answer would be a standard CCT thorax abdomen pelvis along with a bone scan. But
Okay.
if you do have a PET scan at your facility, and we can get it done if it's not much of a constraint of the patient and the resources, then it's a kind of a locally advanced disease. So getting a PET scan won't be out of order. You can get a PET scan done also and look into it. But provided we get an IHC done and get to know, because as Dr. Shreya was saying, that we need to not only root out benign diseases, we need to look into some atypical conditions as well. Like, do we have an inflammatory breast cancer? Do we have a lymphoma of the breast? Do we have a sarcoma of the breast? Before stamping her as primary cancer of the breast. So that would be important.
Okay, Dr. Prashant. So are you going to, if you have to choose between CCT TAP or PET-CT, would you like to add some more investigation to the CCT TAP, or what are you going to do actually for this patient, Dr. Prashant?
Yeah, so if cost is not an issue, I would consider doing a whole body PET CT.
Dr. Prashant, your voice is echoing actually.
Yeah, so can you hear me now?
Yes, it's better.
Yeah, can you hear me now?
Yes, it's better, pretty better. Hello.
Yeah, can you hear me now? Is it clear?
Yes.
Yeah. So if cost is not an issue, I would prefer a whole body PET CT because it is more sensitive and we expect more lesions to be picked up. But if cost is a constraint, then of course CCT TAP with bone scan.
Yes. So as per this National Cancer Guideline of 2019, in these patients, that is T3, T4, or with any N, or N2, N3 disease with any T. So this patient falls in T3, N0 category. The prudent metastatic workup would be at least this chest X-ray and USG abdomen. That is for the low resource setting. That is the minimum you can offer these patients. The optimal would be CCT TAP with bone scan. And obviously, if you have PET CT at your disposal, then that is the best modality for these patients. So for this patient, this was treated at Mahamana. So we had a bit of constraint of PET CT during that period of time. And obviously, this patient was T3N0. So we proceeded with CCT TAP and bone scan for this patient. So on CCT TAP, actually there was a well-defined hypodense lesion around 2.2 into 2 centimeter in the segment 5 of liver. I believe all my panelists can see this lesion on the screen. On bone scan, there was no lesion, and we proceeded with an FNAC from this liver lesion, which came out to be positive for a malignancy. And I must remind that the index biopsy of this patient was invasive breast cancer grade 2 with HER2 positivity. So right now, the diagnosis made was carcinoma right breast, CT3N1M1, oligometastasis at liver with IBC, no specific type, grade 2 with HER positivity. So right now, what are the treatment options? Should we proceed with curative intent or palliative intent? Dr. Deepak, what would you suggest?
Since the patient has only a single metastasis, that is to the liver only.
Yes.
So we'll give her benefit of doubt and we'll start her on some systemic therapy and treat her with a curative intent presently.
Okay, sure. Dr. Gaurav?
Yeah. So has Dr. Abhishek joined? Dr. Abhishek, are you there?
I don't see him actually.
I think he's not
because
there.
I wanted to know if there's an expert in the house. So yes, that the intent would be kind of curative. The reason being that, as you said, this is a spectrum. It's not like all or none law. It's not that the patient will not have a good DFS and PFS. So yes, we'll offer treatment with a kind of a curative rationale in mind. Counsel her as you have the IHCs and the HER2 reports. So PCHP for her would be good enough, and at least 6 cycles, and then maybe we can get a repeat PET CT done, and then take a call.
Okay. So, Dr. Prashant,
Yeah. So
if
I
we
have
complete this,
yeah. So I
yes,
have a slightly contrarian view to this.
Yes.
I mean, it's M1 disease which is having hormone negative and HER2 positive. So it is quite an aggressive biology. So even if we actually ablate the liver lesion, take out the tumor in the breast, it's very likely that she's failing somewhere else in a year or so. So with the availability of say trastuzumab or trastuzumab pertuzumab, I think she would get a reasonably good DFS or at least PFS. And we can circumvent the morbidity of surgery as well as radiation.
Okay. Okay. So this can be a question of this can be a matter of debate also. But for this patient, she was young, only solitary liver metastasis, and HER2 positive with ample of treatment options in this category as well. Even second line, third line is also available. So this patient was after a joint clinic discussion, this patient was treated with a curative intent. My another question to the panel, especially the radiation oncologists, is that if we start with the systemic therapies, particularly in this visceral metastasis, do you expect some issues while delivering the ablative radiation treatment in these patients if you exhaust or the disease responds very well? Dr. Gaurav?
Yeah. So if I get the question right, you mean to say that are we going to face any issues with the liver post completion of our systemic
Yes,
therapy?
especially pertaining to target delineation or delivering the SBRT dose to this liver site.
Two things. One, we have a PET-CT baseline. Secondly, we are going to get a fresh PET-CT as well. If the liver lesion persists, we're going to get an MRI done for the liver and to have a very good look and see if we can kind of delineate it well. Have a good look at its location. We need to plan for the radiotherapy in the sense that has the disease progressed actually in the liver, or has it kind of responded in one side, progressed in the other? That is important. We are going to do a gating. So it's going to be respiratory gating. It's going to be a compression of the abdomen, something to kind of fix the liver. So these are the two things which would keep in mind. And I think if she responds well in the breast as well as the liver, she does not have a kind of oligoprovision elsewhere. I think that, and if Dr. Deepak kind of he is willing to go in for a proper radical surgery, if he becomes operable per se, if she becomes operable, he does a mastectomy axillary clearance as he would do for any radical patient. I'd be happy to take this patient up for a liver-directed SBRT. Or if Madam Shreya, if she is worse with placing an interstitial catheter, we can even go in for a brachytherapy. Or if facilities are available, we can go in for a RFA or something like that.
Yes, Shreya is definitely going to prefer that RFA instead of the interstitial needle. Yes, Shreya, what do you have for us?
So yes, I wanted to say that looking at the size and the location of the lesion, it is very much amenable for undergoing an IR guided ablative therapy, be it RFA or microwave. So difference between RFA and microwave is largely that when lesions are closer to the hilum and close to vessels, major vessels, then we prefer microwave over RFA. Otherwise, RFA is a cheaper procedure. So in this particular case, since the lesion is more towards the periphery of the liver, and RFA can be easily done.
Sure. Dr. Deepak.
Dr. Shreya, one question.
Yes,
please,
sir.
sorry to
Yes,
interrupt.
please proceed.
We don't have RFA or ablation at our facility.
Yes.
The question is that do you utilize triphasic MRI or any MRI of the liver at all before this procedure? CT does fine. Would you be happy with the post-treatment PET-CT or normal CT thorax abdomen for this patient, or would you like to do an MRI for this patient?
So,
Because
sir,
the reason being, we are
Please
ignorant. Actually, we don't know. So that's why I just want to know.
So, sir, before planning any IR procedure for liver or lung, routinely a CCT, and for liver a triphasic CCT suffices. the purpose of triphasic is primarily for the characterization of the lesion, and second is that if the lesion is close to an artery or a vein, then we will be able to delineate the course of the vessels better on a triphasic. So CT suffices, but sometimes if there are lesions which are not easily characterized on a CT, and MRI may be required. And if we are suspecting multiple lesions and we think that CT has lesser soft tissue resolution and maybe we are missing tinier lesions which might change the plan of management, then we would go ahead and do a contrast MRI.
Thank you.
Okay. Dr. Deepak, what you have to offer? You are not audible. You are muted, Deepak. Deepak, you are muted.
Go ahead either in the form of BCT or mastectomy. We'll prefer mastectomy because we don't want to do any local therapy to breast or axilla, because we'll try to continue the systemic therapy, first point. Second thing, we can do a surgery in a same sitting for both the liver met and the breast. So for liver met, the only thing that we have to keep in mind is to do an intraoperative ultrasound, whether you do through laparoscopic or robotic approach, or you do through open approach. So you should have the facility of a intraoperative ultrasound, preferably a radiologist or a trained surgeon who is very well versed with doing intraoperative ultrasounds. After that only you should do a curative intent procedure for the liver solitary met.
Yes. So basically, as I can see that probably all the treatment options are fit for this patient. Surgery, interventional radiology, RFA or MWA along, and obviously SBRT is also available. So right now, how to decide about this? How do we proceed? So I think the choice of the patient needs to be explained about the cost, the procedure, and possible risk and benefit of all the treatment modalities, and let the patient choose. The house agrees with it?
Yes, absolutely.
Yes, absolutely.
So now there are two options. First is as we can see, the therapy for the metastasis, and obviously we have to take care of that primary site, as Dr. Deepak has rightly pointed out. So this is basically a case of synchronous oligometastatic breast cancer. We have some data, retrospective data, obviously, in this regard of benefit of SBRT, and obviously RFA and surgery primarily for the metastatic site has already proven its efficacy and benefit in this oligometastatic site setting. Apart from this, as we have proceeded from this targeted this metastatic directed therapy, right now the question is, how do we combine this local therapy with systemic therapy? As the house has rightly pointed out, that we first need to proceed with systemic therapy. So this offers basically two main purposes. First is the biological selection. If the patient is progressing on chemotherapy and HER-directed therapy, there is no point in treating this patient anymore, as Dr. Prashant has already told. And more so, if the disease responds and well, then we can offer a curative intent treatment, obviously. But there also lies a problem with that. If you are going to offer especially SBRT, then probably if it responds very beautifully, then probably you are going to be in a dilemma of how to target this lesion. So probably a coiling by Dr. Shreya would help in this regard, obviously. Apart from that, when do you go in for this ablative therapy? Do you go in upfront or at the completion of systemic therapy, or you just sandwich this local ablative therapy within the cycles of chemotherapy? And lastly, how is as we have already discussed, the scope of biological selection in these patients? Now, coming to the systemic therapeutic options, we have to fill a big shoes of Dr. Abhishek. My panelist must help me in this. So for this HER2 positive patients, in the first line itself, in the first line itself, if it's hormone positive or HER2 negative, we have to see that. If hormone positive, then we have to add endocrine therapy along with this HER-directed therapy. Right now, is the era of the combined HER2 blockade, that is Trastuzumab plus HER2. You can offer this to this patient as per the affordability and availability. Apart from that, there is an option of chemotherapy as well, along with this HER2-directed therapy. And with that, we can offer in the second line other drugs, that is higher levels of HER2 blockade in the form of TDM1, trastuzumab deruxtecan, and some kind of oral drugs like tucatinib and pan-HER blockade as well. So these are the options of systemic therapy available for HER2 patients, HER2 positive patients with us. Now, the next question is the therapy for the primary. And do we proceed with the local radiation or not? So Dr. Deepak, any suggestion on local, how beneficial would be this surgery for local site in a metastatic and oligometastatic breast cancer?
So, like I've already described, after a MDT, if we have planned for a curative intent for this patient. So first of all, what we'll do is we'll plan whether we want to do a surgical resection for the metastasis or we want to do some local therapy. If let's say supposedly for most of the patients, we combine SBRT with local radiotherapy in post-op. So the caveat that we are planning to treat this patient with a curative intent. So we should never mix intent. So if you're planning to treat this patient with a curative intent and we're planning to remove the liver met, then she should get a local therapy as prescribed by the loco-regional recurrence rate as per the nodal and the primary tumor burden. So if the primary tumor burden or the nodal burden after the histopathology warrants a local radiation, she should receive one. However, as per our setting, we'll plan for a accelerated passive breast radiation with limited number of doses so that the radiation cycle is for a shorter duration. I think more light would be put upon by Dr. Gaurav regarding this.
No, I absolutely agree. Dr. Deepak does BCS quite well, and we are happy to treat his patients for the last couple of years, and we have had excellent results with BCS also. But considering that if he wants to take up this patient for MRM with an axillary dissection, plus or minus, we would be happy to treat this patient with adjuvant RT to the chest wall, because we are treating this patient with a radical intent. And we'll be using the fast forward the regimen, as Dr. Deepak said, that we must hasten the treatment which will hold on to her systemic therapy. So if Dr. Deepak is happy to do a mastectomy for her, would be happy to take the patient up for a fast forward adjuvant radiation to the chest wall.
Okay. This fast forward, this extreme hypofractionation is we are considering just to shorten the duration of the radiotherapy so that the patient doesn't miss or we don't prolong the systemic therapy in this patient. So fair enough?
Yes, absolutely.
Yes. So actually, after an MDT discussion and the discussion with the patient, this patient was offered SBRT to this liver lesion of 50 gray in 5 fractions. And finally, this patient was offered complete systemic therapy as well. After that, surgery after NACT, the post-op HPR came out to be after mastectomy, YP-T1B and 0. As Dr. Gaurav has pointed out, this patient received extreme hypofractionated radiotherapy to the chest wall and SCF. And this patient completed maintenance trastuzumab in April 2024, and subsequent response scan after 3 months showed no evidence of disease at the metastatic site, and this patient was disease-free on the last follow-up after around 6 or 8 months of treatment, 8 to 9 months of treatment. In January 2025, this patient was disease-free for as of now. So this is for the first case. Now coming to the second case. This is a 65-year-old lady, post-hysterectomy, diabetic, hypertensive, as well as hypothyroid on regular medications. No suggestive family history. Has presented with the right breast lump since 3 months. On examination, she has a 3 into 3 centimeter breast lump in upper outer quadrant. Skin is free, but she has multiple matted axillary lymph node. And the contralateral breast and systemic examinations, contralateral axilla is normal. So on the initial diagnosis, this patient is non-metastatic on PET-CT. PET-CT was done because it was staged as N2 disease upfront. Patient completed treatment in July 22. The completed radiation treatment as well, was on hormone therapy. But after 14 months into follow-up, that is after this radiation completion, this patient is right now complaining of pain in the neck and pain near the left side hip joint. So how do we proceed? Dr. Prashant?
Yeah, so again, we'll have to do an imaging either with PET-CT if affordable or CCT-TAP with bone scan. So depending on if you find metastasis, then depending on the location, we would have to consider for a repeat biopsy, because if it is only a bone lesion, doing a repeat biopsy is not going to give us proper IHC. But if there is a soft tissue mass combined with a bone lesion, you can take out the biopsy from that soft tissue mass and repeat an IHC, because initially she was hormone positive. So there is a 15% chance that she could, the hormone status may change. That's how I would proceed.
Yes. So actually, as Dr. Prashant has already pointed out, the location and the nature of that metastatic lesion is important to take a biopsy. Obviously, the biopsy is important and is preferred, but we have to be we have to be able to take that biopsy. So for this patient, as we have seen, we proceeded with PET-CT, which is the most sensitive and probably the most specific as well in this investigation modalities. And hormone positive patients, this patient was actually hormone positive, 8 and FIS not amplified. So these patients usually do fall in the bone as the most common site. So we have to keep that in mind as well. And patient was proceeded with PET-CT. So pertaining to the biopsy, as seen from this paper in 2021, actually the nature of the metastatic disease changes in almost every subtype of primary breast cancer. Like as we can see in primary hormone positive, HER2 negative, around 60% of the patients do change the biopsy. They do change the nature of the hormone in the metastatic setting. In primary TNBC also 18% of patients do change. The most drastic changes occur in the HER positive or triple positive patients. Sometimes, most of the time, they lose their HR or lose their hormone positivity. So accordingly, you have to titrate your treatment and you have to direct your systemic therapy in that line to align as per the disease biology. So that is why we would always prefer to get a repeat biopsy from that metastatic site done with the help of our radiologist or surgeon, whatever is feasible. Now, for this patient, as Dr. Prashant has already explained, it was only bony site with no perceivable soft tissue lesion. So biopsy was not possible in her case. On PET-CT, there was a lesion in this transverse here in the C1 vertebra, and there was another lesion in the left side neck of the femur, not exactly neck of the femur, lower down, probably near the lesser trochanter or somewhere there on the left side. So this patient was diagnosed as metachronous oligometastatic right side breast cancer with bone only metastasis. Now, treatment options for this patient. Dr. Deepak, what would you like to offer for this? You are muted, Dr. Deepak. Dr. Deepak, you are not audible, you are mute.
Hormone positive tumor recurrence, because in 5 out of 6 patients will have a nearly similar histology and ISC receptor status for patients who recur. Secondly, there are 2 lesions. One lesion can be operated, that is the lesser trochanter lesion you're talking about of left. But the lesion in the cervical vertebra is, I think, difficult to operate, much better evaluated by our neurosurgeon or by our the BST team and Dr. Sarup. So I would like to prefer a common modality for both the lesions. So I would prefer not to do a surgery. However, we'll try to start with some systemic therapy so as to assess the biology of the recurrence that we see presently.
So, Dr. Shreya,
Yes, sir.
anything from the interventional radiology side to offer in these 2 sites? Let's
So,
have a
sir,
look at the lesions as well.
yes, so sir, in bone metastasis, again, we have ablative options of giving ablative therapies, but the location is such that the access might be difficult. So for bone lesions with large soft tissue component, RFA, microwave, and cryoablation are the options. But because the lesion is very small and primarily intramedullary, there is not much soft tissue component. Doing an RFA and microwave ablation may or may not give good results. Meaning the lesion is so subtle and hardly seen on CT. It is primarily picked up on PET. So when we are doing targeted therapy, we need to be able to see the lesion very well on CT to know what to target. So if lesions are subtle on CT, we may not be targeting we may not be going into the core of the lesion.
So, Dr. Gaurav, what do you have at your disposal to offer?
I wouldn't play around much with this patient. Could you just go back to the treatment summary page, the slide we showed her treatment till date?
For
Could you
this
just go back?
patient?
Yeah, for this patient.
Like till date.
Yeah, the one back. Yeah, this one. So this is what she had. She finished her treatment. She's completed her treatment quite some back. She was on AI, and it was a good 14 months since she had this disease, since she had the symptoms. I think the next best step would be, considering her age, is that we focus on the systemic part, add bisphosphonate or denosumab, as the case would be, and keep her on close observation, keep her on follow-up, and if, because we are not doing a repeat biopsy for this patient, if she does progress, and if it is progression at a new site, we get additional information in the form of soft tissues, get new biopsy lesions, get a rebiopsy done, and then decide. But for the time being, I wouldn't offer her, because the only complaint is pain. Now, obviously, we can go ahead and do kind of an SBRT for the lesion which is there in the femur. But I don't think that's a prudent to do for her case, because I believe that whether you use zoledronic acid or whether you use denosumab, along with the next line kind of the hormonal therapy, I think she should fit fine. She should respond. And were she to not respond, we always have an option to kind of escalate treatment and kind of look for a new biopsy if and when she does develop a new kind of a lesion with a soft tissue component. So I would just offer her next line systemic therapy. That would be
Okay. Okay. Dr. Prashant. Dr. Prashant, are you there?
Yeah.
So
Of course,
are you going to wait a bit, or are you going to go in all guns blazing?
of course, systemic therapy, she has been on AI. So the probable next option would be going on to fulvestrant, plus or minus CDK4 inhibitors. But of course, she's old, so she may not tolerate the CDK4 inhibitor. So fulvestrant is one option. Regarding the local therapy, the lesion in the femur actually looks more of a bone marrow uptake rather than a cortical lesion. So, yeah, ablating, I mean, I don't have the CT images, so I don't know whether it's a cortex, but it looks like a bone marrow lesion. So, SBRT probably is no use there. The C1 lesion seems amenable for ablation.
Okay,
Apart from
this,
changing, apart from changing the systemic therapy, I may give a lighter dose of SBRT to the C1 lesion and keep her on follow-up.
yes,
Because
a lighter
biologically,
dose,
she's
softer
having good
fractionation.
disease.
Lighter dose means softer dose fractionation, you mean to say?
Yes. Softer dose fractionation, because it is kind of close to brainstem spinal cord junction.
Okay, sure. So for this femur, it was discussed with the nuclear medicine and the radiologist as well, and it was a cortical uptake basically. So not in the medulla or not in the marrow. So it was confirmed to be a this soft femur or just below the lesser trochanter of the left side femur uptake. So obviously, from the radiation oncologist perspective, may I conclude safely with the permission of my radiation oncologist that this femur lesion is actually a doubtful site to go in all guns blazing, because there is a high risk of fracture if we treat this area with SBRT. Does the radiation oncologist agree with me?
Yeah, surely, absolutely.
Okay. So for this patient, the diagnosis was obviously metachronous oligometastatic. We have seen this. And radiotherapy, the technical difficulties we already have discussed. The Dr. Gaurav and Dr. Prashant have already highlighted this. Surgery and stabilization, Dr. Deepak has already elaborated on that. So for this, for spine metastasis, actually, we can go through this ISRS recommendation for patient selection for consideration of SBRT outside a clinical trial. Here, they recommend that oligometastasis involving spine, patients with radio-resistant histology, that is RCC melanoma or sarcoma, they are preferred for SBRT treatment rather than a moderately hypofractionated kind of palliative dose fractionation radius, like dose like 4 gray per fraction or 3 gray per fraction. And apart from that, even patients with paraspinal extension contiguous to the spine can also get better pain relief with SBRT as per the ISRS recommendation. Apart from that, we have to consider the SIN scoring or the spinal instability scoring. Apart from that, for the functional outcome point of view, we may have to go through this norms criteria as well to choose the best treatment options available for this patient. And finally, we have to decide what we need to do for this patient particularly. As we can see, we were pretty apprehensive about the complication of the SBRT treatment for a long bone. From this paper, we can see that at median follow-up of around 21 months, this paper analyzed 114 metastasis of femur, humerus, tibia, etc. Treated in 111 patients, and the fracture rate was below 10% at around 3 years. And at 1 year, it was only 3.5%, reaching up to 9.8% at 3 years. And the local failure rate was also below 15% over a period of 3 years. So probably, yes, it's difficult to treat these sites, but still, the surgery is going to be difficult for that patient at that particular site. Even interventional radiology has a very little options to offer. So probably the SBRT, if possible, for that particular femur lesion is the best possible option to offer if feasible and if it can be done properly in a safe way. Now, coming to the systemic therapy plan, the same for hormone positive metastatic breast cancer. The first line treatment this patient was offered was obviously the aromatase inhibitor in a postmenopausal lady. But right now she has progressed, and in the first line, we may add CDK4/6 inhibitor for this patient. But as Dr. Prashant has pointed out, in an old lady of 65 years, there might be some issues with the tolerability of this CDK inhibitors, the abemaciclib or ribociclib and palbociclib, but still we can try a bit with this. If it progresses on these CDK4/6 inhibitor along with the endocrine therapy, then we have to again look at the genetic mutations of these patients, like if we can offer everolimus, mTOR inhibitor, PIK3C mutation, then alpelisib. And if there is any germline mutation, BRCA, BRCA1, BRCA2, then we can proceed with the PARP inhibitors as well. So these are the options. And obviously, if the patient progresses to a systemic or visceral crisis, then probably we may have to add some type of chemotherapy as well for this patient. Apart from that, for this patient, again, she was decided in the GC to be treated in curative intent and proceed with the treatment, not to wait with only escalation of the hormone therapy and a bone stabilizing agent such as denosumab or zoledronic acid. So we decided to treat all the lesions, all the metastatic lesions. So proceeded with SBRT2 bone meds, added a palbociclib to this patient. Palbociclib was added because of cost considerations. We have a generic available for this palbociclib. Apart from that, as Dr. Gaurav has already mentioned, started on a monthly zoledronic acid as a bone stabilizing agent. So we treated with this femur. Dr. Prashant had told that C1, it's a risky area. So it was with softer fractionation of 35 gray in 5 fraction at 7 gray per fraction. And the femur area, the care was taken not to irradiate the whole circumference of the femur, only the disease with leaving behind safely a cortical bone tissue around that lesion, so that we do not risk the patient for fracture. It was taken with great care and delivered a dose of 24 gray in 3 fraction at 8 gray per fraction safely. As of now, this is the response scan. C1 and femur both are actually well in control. On the last follow-up on 29th of January, the disease status of this patient was also controlled. So coming to the take-home message from this discussion of all my esteemed panelists, synchronous oligometastasis breast cancer are rare, around 6 to 10% of patients, but are increasingly being detected due to sensitive diagnostic modalities. The patient selection has to be meticulous and patient-centric with a participation from the patient side as well, to be able to offer the best possible treatment to this patient. The individualized, that is called the individualized treatment, basically, in my opinion, apart from this genetics and drugs. So there are a few questions to answer. Till now, there is no robust level 1 data to support or refute the treatment of these patients for now. And can systemic therapy akin to non-metastatic patient be considered after ablative treatment for metastatic site? Like in the first patients in synchronous oligometastatic patient, do we stop the maintenance therapy as we do with the curative intent patient, like after 1 year of trastuzumab HER2-directed therapy, or 5 or 7 years of hormone therapy, or 2 years of pembrolizumab, or do we keep on giving these drugs as we do till progression in a metastatic setting? So this is food for thought for my panelists and all the audience as well. And lastly, recently some data has come about SBRT not being that beneficial, especially this NRG-BR002, which has been published as an abstract only. And some preclinical studies are also available, which are saying that maybe SBRT might not be beneficial to that extent which we expect it to be. And in some cases may worsen the disease, overall disease outcome as well. So we need to wait for the mature data from these results and these studies to proceed further in this regard. But still, finally, the disease biology remains the king, and the patient herself or himself is the most important stakeholder to be considered in his or her treatment. So thank you. That's all from my side. Thank you to all my panelists for your great participation and cooperation. Thank you. Thanks a lot.
Thank you, Dr. Lincoln.
Thank you, sir. Thank you.
Lincoln, do you have a minute? Hello?
Yes, tell me. I'm
Yes.
all my ears to you.
Yeah. As I said that, yes. So as I said that for this the second case, we will be
Yes.
escalating the systemic therapy and with the Zolria, the denosumab. And I also kind of agree with your decision to kind of put the patient on palbo for economic reasons as well as titrability. Like you can always kind of de-escalate the dose and give her breaks, and rather than just let her be, I think she should be offered CDK4/6. And I totally agree with you. The SBRT, one question I would like to ask you regarding, like, for the information of the audiences, like when you did the SBRT to the femur. So I would just like you to just enlighten the audience regarding how would you go about the fixation regarding, because you're going to give it as a multifractional therapy. So how did you go about regarding the fixation for the
Yes.
daily setup?
You mean to
Similar.
say immobilization?
Yes, remobilize. Yes.
Yes. So at our center, when we treated this patient, we didn't have much of fancy gadgets with us, but we could achieve a reasonable fixation with backlock only. If needed, we sometimes use, after making a backlock, we sometimes use cast over it as well. And right now at our hospital, we have customized extremity immobilization devices as well. They are available commercially as well. So this also can be taken into consideration if you want to take help. So the second thing is that when you are not sure of that immobilization, then you may have to take more margin, but as per the site of this lesion, it may not be prudent to take an increased margin. So it's all the best possible immobilization, whatever you have.
അവള് പറഞ്ഞു അവളിപ്പോ ഫോൺ വിളിച്ച് എന്റെ അടുത്ത് തരുന്നെന്ന് പറഞ്ഞു.
SBRT,
അവള് ഫോൺ
so
വിളിച്ചവന്
you have
പൈസ
to
കൊടുത്തിട്ടാണ്
offer
തന്നത്.
online matching, meticulous online matching
ഇല്ല പറഞ്ഞില്ല, പറയാം.
prior to treatment. So that's from my side.
Thank you, Lincoln. Only time will tell whether we can kind of phase out SBRT or not, considering the giant steps the systemic therapy is taken. Because one thing is for sure, we can never compare the older studies with the new ones, because there the treatment, the delivery of the radiation, the vaccination was different. The era of systemic therapy was entirely different. And as we know, like I just want to point out that we are now into the era of radioimmunotherapy. You will be well aware of that. And we know that radiation is a radiosensitizer. And we could always like consider, because there have been very small trials considering radioimmunotherapy or SBRT. And I think that this is always an evolving subject. And I feel that the goalpost is always moving. So you can never say when you have scored a goal. If you have scored last night, tonight it will be different because the post has moved. Because our colleagues in surgical oncology, in systemic, in medical oncology, they are making strides day in, day out. So I think we can, yes, as you rightly said, a very good selection of the patients is very much essential to get good results, which are replicable, which are verifiable, and which hold the test of time. So I think we should all kind of just keep sharpen our skills. All three branches, including Dr. Shreya also, all four branches, and we can try and offer as much as possible the best option which is possible to the patient, which is currently available and feasible. Thank you, Lincoln, for this wonderful talk.
Yes, the great old saying, there is no I in the team. It's always we.
Wonderful to have you today this evening.
And Dr. Deepak is not smiling. He probably doesn't agree with me.
Why would I not agree? I'm the only one who has worked with both of you.
Must, buddy. Okay, thank you. Thanks a lot, my
Okay.
esteemed panelist.
Thank you.
Great seeing you this evening.
Oh, good day.
Thank you.
Thank you so much, sir and ma'am. Now, I would like to conclude our session by thanking our esteemed speaker, Dr. Lincoln Pujari, sir, and our panelists, Dr. Deepak Kumar Singh, Dr. Gaurav Goswami, sir, Dr. Shreya Shukla, ma'am, and Dr. Prashant Girdhar, sir. Thank you so much, ma'am, for taking out your precious time and dedicating to our platform. Thank you, sir.
Thank you.
Thank you. Good day.